In this capture, we're going to begin looking at infectious genitourinary disorders. Before we go there, let's just take a moment to review GU assessment. When we're talking about health history, the focus really needs to be on the patient's typical pattern. How often are they going? The frequency, how much are they typically going? Do they void large amounts at once? And really kind of keying in on any recent changes. Okay. Hesitancy. I want to make a note about that real quick because that's something that you really want to address with our male patients, because as they get prostate enlargement, which is very common as men age, they can have issues with initiating their stream. So you want to make sure you're asking about that, as well as decreased strength or force of their stream. Certainly, you want to ask about any dysuria or difficult or painful urination. If they're having nocturia, where they're getting up multiple times during the night to go to the bathroom. And of course, hematuria, if they're noticing any blood or discoloration of their urine. Do keep in mind that hematuria can be gross in the sense that we can see it with our eyes, or it can be microscopic where it's only identified in the lab. You want to take a look at their past medical and past surgical history, because those things can certainly be influencing their urinary pattern. For example, patients with diabetes, it's a normal function of the body to try to rid excess glucose through the urine. So that's one of the reasons why they tend to urinate more frequently, because that's the body's way of getting rid of that excess glucose. Certainly noting past surgical history, and of course if they have an ostomy, and in this case we're kind of focusing on a urostomy that drains the urine. You want to know about their medications. There's certain meds that obviously are going to make them urinate more, your diuretics, and there's other medications that may actually cause urinary retention, so you want to keep note of that. You also want to note their dietary intake. Again, if they're drinking lots of fluids, what goes in must come out. So you should have a balance plus or minus 200 milliliters within a 24-hour period. For the physical exam, you want to make sure you're looking at the appearance of the urine. What color is it? What's the clarity? Is there any odor, particularly foul odor that tends to indicate infection? In some cases, you may need to actually inspect the urinary meatus, especially if we're talking about cases of trauma. We may need to percuss the posterior flank around the kidney area, looking for, some tenderness there. Also, percussion and palpation of the bladder. Remember, if the bladder is empty, you should not be able to palpate it. Other parts of the exam would be the digital rectal exam. This is mainly done by providers. Nurses aren't typically doing this, but we'll talk about the DRE in relation to enlarged prostate and prostate cancer. And then, of course, the testicular exam. Again, this also includes instruction by the nurse teaching the patient about testicular self-exams. Looking at GU-related diagnostic studies, let's start with the urine. You're probably very familiar with the urinalysis, or what we often call UA, and also the culture and sensitivity, the C and S. So the urinalysis looks at multiple things within the urine: the color, the clarity, presence of red blood cells, presence of white cells, presence of protein, glucose, nitrates, and it's a little bit more in the list. But it's a screening tool. It tells us if something's there. It also looks at specific gravity. The culture and sensitivity we use specifically when we suspect that there is an infection. So the culture piece is aimed at growing out any bacteria that is present in the urine. And then once that bacteria grows out, the sensitivity piece is subjecting that grown out bacteria to different antibiotics to determine, is it susceptible to that antibiotic or is it resistant? And that helps guide our therapy. Keeping in mind urine samples, we typically have what we call a clean catch or a sterile specimen. The clean catch is what you're likely going to see in a clinic and a lot of times in the emergency room. This is where we're giving the patient the little antiseptic wipes. They're cleaning their genital area, again, front to back. Females really should be holding that labia open. They start urinating, and we do a midstream specimen. A sterile specimen, here's where we're actually using a catheter to collect the urine. Other urine studies include a stone analysis, and this is for patients with urinary calculi. If they're able to pass a stone, we send that stone to the lab for analysis to figure out what are the components. And that can be very helpful in trying to prevent future kidney stones. We look at a post-void residual. So this would be a collection or measurement of urine after they're going to go, and then we're going to look and see what is left in the bladder. Typically, we are doing this with a bladder scan, the ultrasound, to kind of tell us what's left in the bladder. And then depending on what that result is, we may or may not need to catheterize them to get that excess urine out. We also have 24-hour urines, and it's important to know when we're talking about a 24-hour urine, it's a 24-hour period, obviously, but when it begins, like let's say we're starting it at 0800, I'm going to have the patient urinate at 0800, and that first specimen of urine gets thrown away. And then after that, we're keeping every single drop of urine for that 24 hours. It goes into a collection container. It does need to stay refrigerated, or if your patient has a Foley and we're doing a 24-hour urine, that Foley bag needs to actually be sitting in a basin with ice. Okay, if they miss even one drop of urine, they have an incontinent episode, we need to start the whole process over again. We also have blood studies that look at genitourinary things, BUN and creatinine, and I would also add GFR, glomerular filtration rate. Those things look overall at kidney function. We look at electrolytes because electrolytes excretion and retention is actually controlled by the kidneys, so that can tell us a lot about kidney function as well. We also look at tumor markers, and we're specifically going to talk about prostate-specific antigen, or PSA, as we get into our prostate cancer discussions in class 3, where we look at malignant disorders. There are also cultures. We talked about the urine culture, but we can also culture other body sources, and this mainly comes into play when we talk about STIs, sexually transmitted infections, where we're taking urethral cultures, rectal cultures, that sort of thing to identify a causative agent. Continuing on with diagnostic studies, diagnostic imaging, most common is going to be a typical X-ray. We call that a KUB, where we're just taking a flat plate of the abdomen. It's a single view looking at the kidneys, ureter, and bladder. We can look at ultrasound, and it depends on what type of an ultrasound we're looking at. If we're focusing on the pelvis, patients need to have a full bladder in order to do that ultrasound, so keep that in mind for patient prep. CTs and MRIs can be done with and without contrast. And when I'm talking about contrast, I'm talking about IV contrast. So make sure you're assessing your patients for allergies to shellfish, iodine, betadine. Okay. You also, with that IV contrast, want to pay attention to their kidney function, their GFR, because that contrast dye is really, really harsh on the kidneys. Also, if you have a diabetic patient and they're on metformin or glucophage, that medication would need to be held at least 48 hours post-study with IV contrast. Nuclear scans are very similar, except the contrast that they use is a radioactive isotope. An IV urography is a system-specific assessment where we're actually using IV dye. We insert it into the bladder. We can also give intravenously to see how things are progressing through the urinary system. Renal angiography involves threading a catheter up through the arterial system and then looking specifically at the renal arteries. That is commonly done if your patient is developing some kidney issues, or if they have unexplained hypertension, because the kidneys are very important in the ongoing control and management of blood pressure. Of course, a biopsy is a collection of a specimen, and in general, when we're doing a biopsy, we're looking to, rule in or rule out a potential malignancy. Finally, endoscopy. There's a couple things that we can look at. Our most common is going to be cystoscopy, where we insert a scope with a camera on it through the urethra into the bladder to actually visualize the bladder. Now, they can actually go further and go what they call a ureteroscopy and actually visualize the ureters. And in some cases, they actually do treatment with that if they're trying to retrieve kidney stones or take specimens and that sort of thing. Okay? All right, so let's look specifically at infectious things. We'll talk about UTI, very basic pathophys and etiology. Essentially, the bacteria ascend the urethra. They're like climbing up like a ladder. They attach to the bladder wall and they start multiplying. Most of the time, your infections are going to be caused by E. coli because that is normal flora in the bowel. Now, thinking about this from a risk factor perspective, ladies, we get the short end of the stick. And it has to do with the proximity of the urethra to both the vagina and the anus, and the fact that we just have a shorter urethra. There's less distance for that bacteria to have to travel. Poor perineal hygiene is also associated with this. This is why it's very important when you're doing perineal care. We're cleaning front to back. We are using different parts of the washcloth. We need to make sure we're educating patients on proper perineal hygiene, because if they're wiping back to front, they're essentially taking the bacteria from the rectal and the vaginal area and bringing it up to the urinary meatus of the urethra. Other risk factors include obstructed urine flow. So this could be from anything from a kidney stone, a ureteral stricture, or a change in the angle at the UV junction, the ureterovesical junction. Usually that reflux piece, that's usually a congenital issue. It can be a bladder prolapse, where you actually have part of the bladder sitting outside the urethra. That's going to put them at risk for infection. Incomplete bladder emptying, because again, we're providing a perfect medium for bacteria to multiply. Certainly if they're immunosuppressed, or patients that are diabetic. Again, diabetics are going to excrete excess sugar through their urine. It's part of their body process. However, bacteria love sugar, so that gives them a perfect medium to feed on and multiply. And finally, the last big risk factor is going to be urinary instrumentation. So use of a catheter, the ureteroscope, anything like that, we could potentially introduce external bacteria into the bladder. So what are we going to see? And we actually classify UTIs based anatomically, lower and upper. So lower UTI would be things, cystitis, it's controlled to the bladder, or kind of in the bladder. Prostatitis for males particularly is considered a lower UTI and inflammation. And urethritis, so now you have infection of the urethra. Symptoms you're going to see: frequent urination, urgency. A lot of times when they do go, they're avoiding small amounts. They may have some suprapubic discomfort, and their urine is most likely going to be cloudy. Now, when we talk about an upper UTI, now we're talking about kidney involvement, and that's known as pyelonephritis. So symptoms you're going to see all the stuff you would see as lower UTI. They're going to have flank pain or low back pain, and they often have fever and chills. I have a notation on there about gerontologic considerations. Something you need to keep in mind: your older adults may not present with any symptoms at all, with the exception of increased confusion and perhaps increased incontinence. Many, many times that's what we're seeing in our older adult population. They don't necessarily have the classic UTI symptoms. So just keep that in the back of your head. So lab and diagnostic testing, we're going to get that urine sample. That UA is likely going to show nitrites, WBCs, and leukocyte esterase. We are going to send it for culture and sensitivity. Again, we want to ID the bacteria type and be able to select a treatment agent. There is a video posted on Plato that reviews how to interpret a culture and sensitivity. It would behoove you to watch that because you never know when you might be quizzed on it. Upper and complicated UTIs may also lead to sepsis. So if that's the case, we're looking at some additional testing. We'll look at the CBC, specifically an elevation of white blood cells and specifically neutrophils within the CBC differential. We may be doing blood cultures, and we would be looking at serum lactic acid. Okay, that's going to be a good indicator of if we're looking at sepsis. Chronic pyelonephritis, so people that have repeated episodes or their case never really goes away, they have that chronic issue, that they really need to be evaluated for what is causing it and even the development of renal damage. Every single inflammation, if it involves the kidney, is going to cause some damage. So the cumulative effects of that can be quite damaging. Treating, we're going to hit it twofold, well, really threefold if you think about it, but antibiotic therapy, because we need to treat the underlying cause. So commonly used agents include macrodantin, Bactrim DS, and Cipro. Again, educate your patients. They need to be compliant with the regimen. They need to make sure they're taking their medication on time, and they need to finish all the pills to make sure we've eradicated this infection. We are also going to treat their symptoms. So pyridium is a urinary analgesic that works wonders. It is absolutely wonderful. It will turn your patient's urine orange, so you definitely want to tell them that. We can use acetaminophen or NSAIDs, for discomfort, pain management. If they have a fever that's bothering them, that'll help manage that. If they're having nausea with it, we may be using antiemetics, although that's not something you commonly see. That's only going to be a specific symptomatic treatment. We can also use sitz baths if your patient is having some external irritation at the urethra. That can help manage that. Pushing fluids, whether they're IV if they're an inpatient or PO as an inpatient and an outpatient, is going to be helpful for several reasons. First of all, the more they drink, the more they're going to pee. So we want this to be a one-way street. We want to flush this bacteria out of our system. Secondly, the antibiotics and other medications that we're using to treat the infection or to treat the symptoms, those have to get metabolized and excreted from the body in some way. And a lot of that occurs in the kidneys. So if the kidneys are not well hydrated, we can actually cause damage to the nephrons because of the toxicity of the medication. So it's very, very important that these patients stay hydrated. On that note, we want, unless there's contraindications, certainly if they have a history of heart failure, I can't push 3 liters of fluid on them. But if they can tolerate it, we want them to have at least 3 liters of fluid every day. As much as possible, we want to acidify the urine. We can do that with pure cranberry juice. Bacteria have more of a difficult time growing and multiplying in an acidic environment. So the research is kind of mixed on this. Cranberry juice, the acidic environment, has been known to help prevent UTIs, but acidifying the urine by itself when there's an infection present usually is not going to be enough. The other thing we recommend, especially if the patients are having irritation symptoms, is to try to avoid caffeine, coffee, tea, citrus fruits, chocolate, and alcohol, because those things tend to irritate the urinary tract. You want to teach patients to void every 3 to 4 hours while awake. Even if they don't have the urge to void, we want them to empty their bladder. That's going to help prevent buildup of the urine. It helps prevent a situation where we have an environment where bacteria love to grow, and we just want to try to prevent this or minimize it as much as possible. Females especially, but also males, but especially females, should be encouraged to urinate both before and especially after intercourse. I'm not going to get all graphic, but there are sloshing of fluids, and bacteria can get up the urethra. So actively urinating after intercourse will help flush some of that bacteria back out, that it's not getting up to the bladder. We already mentioned personal hygiene earlier as a risk factor. Showers are recommended over baths simply because the shower helps wash the bacteria away, as opposed to a bath where you're sitting in stagnant water and it's sitting there right at the opening of the urethra. Avoiding bubble baths, watching your feminine products that contain perfumes or irritants, that's pretty important because that can cause some irritation and, again, an environment where bacterial growth can just thrive. Avoid sitting in wet bathing suits or wet clothing, and avoiding tight clothing is very helpful to try to prevent UTIs. For prostatitis, a lot of stuff is going to be very similar to UTI, so I'm just going to hit some key points. There are different types of prostatitis. There's acute, chronic, and obstructive. Acute is very much like a UTI. Chronic, we have difficulty treating. They have some chronic irritation with periodic flare-ups. And obstructive is typically due to a very enlarged prostate. Again, the most common cause is going to be bacteria. Our E. coli is, again, our biggest offender. Risk factors for this include stress and also long periods of sitting. So you think about occupations like over-the-road truck drivers that are sitting a lot because they're driving. Signs and symptoms are very similar to a very severe UTI. They usually have a sudden onset fever, and they have very, very painful prostatic pain. So it's very, very uncomfortable for them. Diagnosis-wise, we'll do the UA-CNS. They will also do a prostatic fluid analysis. So yes, we're essentially need to get them to ejaculate because that's what we're talking about, prostatic fluid. And then they will analyze that for infection and that sort of thing. Treatment-wise, we'll use antibiotics to treat the underlying cause infection. We'll use NSAIDs to manage the discomfort. Alpha adrenergic blockers we'll talk about later on, but essentially they relax the prostate, the smooth muscle of the prostate, so that can relieve some of the symptoms. Sitz baths can be helpful, and reduction of prostatic fluid through intercourse or manual stimulation. Something to keep in mind if they're involving a partner with this is to make sure if they're using intercourse that they are using a barrier device such as a condom, because you don't want to infect the partner and have the partner reinfect back. So that's something to think about. Looking at STIs, again, key points. Regarding treatment, it really depends on what the causative agent is. If it is a bacterial infection, we can eradicate the infection with antibiotics. If it is viral, we can treat it with antivirals, but essentially that virus remains in the body forever, so it never completely goes away, and then they can have flare-ups. So it's really important to understand what the causative agent is for the specific STI. Females, many times, are asymptomatic, okay? So they may not even know that they're infected, and that's a problem because delayed or absent treatment can cause long-term damage, resulting in long-term chronic pain and actually infertility. Common symptoms for females and males include itching, perineal pain, blisters and lesions, and discharge from the urethral vaginal area. It's very important as part of treatment that they identify and treat any sexual partners of the patient who is infected. Otherwise, you're just going to have people reinfecting, and you have what we call the tree of infection. So our real focus is going to be about preventing transmission and teaching our patients of strategies to prevent transmission. And then again, we want to avoid reinfection. Looking at herpes in particular, this is transmitted by direct contact when a carrier is symptomatic. And that's really important. It's when they're symptomatic. Again, this is a virus, so it stays dormant in the body, and then there's flare-ups. So these flare-ups are generally associated with stress, sunburn, dental work, if you're getting inadequate rest and nutrition, essentially your immune system kind of gets run down and it allows this infection to kind of rear its ugly head. Symptoms, they're going to get a painful, itchy macule, papule, or vesicle. They're going to have lesions, perineal swelling, dysuria. They might have a fever and malaise. Again, active cases we're going to treat with antivirals. Typically, we'll use acyclovir, valacyclovir, something like that. Principles of this are very similar to antibiotics. They need to make sure they're taking their medication. They need to make sure they finish the whole course. And then the other piece of it is really trying to build back up their immune system. So good nutrition, good hydration, adequate rest to really build their body back up. Looking at syphilis, this is a bacterial STI and it has multiple stages. So stage 1 is going to show itself as a painless canker type lesion. So this is where people need to be, kind of looking at themselves to see if they're noticing anything like that. Eventually that lesion will actually go away on its own. Your body actually, the immune system takes care of it. As it progresses to stage 2, people tend to develop a rash on their palms and soles. They'll have a fever, they'll have that malaise, that just achy feeling, weight loss, arthritis. Keep in mind, stages 1 and stages 2 is very, very contagious. This is when they can spread it. Then your body kind of takes care of it and it kind of goes away. It goes into what we call a latency period. Later on, it can manifest in what we call the tertiary stage, and it causes progressive inflammation in the neuro and the vascular systems. It is actually thought many cases of dementia relate back to untreated syphilis from back in the 30s and the 40s. Syphilis is very easily treated. We can treat it with penicillin G or doxycycline. We can eradicate this infection. It's a matter of identifying it and treating it. Looking at chlamydia and gonorrhea, again, most of these cases can be asymptomatic. If they are having symptoms, men typically have burning during urination. There'll be penile discharge. A lot of times there's testicular swelling and pain with gonorrhea in particular. Women will have cervical inflammation and they generally have purulent discharge coming from the vagina. We can treat these with different antibiotics, but again, it's all about identifying that it's there, getting the culture, treating the infection, and then educating the patient about trying to prevent retransmission and reinfection. So in the physical exam, you want to observe for rashes and lesions, certainly discharge. Make sure you're looking in the pelvic area for lymph node enlargement, and you have to look everywhere. You need to look at the oral cavity because of oral sex. You need to look at the abdominal and pelvic exam. You need to look in the rectal region, just everything. Diagnostic testing, again, once we get those culture samples, we'll do a gram stain and the culture of the discharge. They can do nucleic acid amplification tests. Basically, they're looking at identifying the causative factor. And again, as I mentioned, you may need to get specimen sources from several locations. Treatment, again, important to treat partners concurrently. And the other thing I want to mention is for certain infectious diseases, there is mandatory reporting to the Department of Health. Now, that is confidential mandatory reporting, but it does have to get reported to the Department of Health. And identifying partners to be able to treat them is very important. With client education, certainly you need to educate them on how STIs spread. You want to talk to them about the treatment, again, finishing the medication completely. For the viral infections, teaching them that it never completely goes away. It's dormant in the body and it can flare up. They need to know about that. Certainly they need to know about preventing reinfection. So talking to them about condoms and other barrier devices for safer sex. The only true, completely safe, 100% way to prevent this is going to be abstinence. Until treatment is completed, transmission is very likely. So all partners must be treated at the same time. So it's very important to ID all sexual partners. The other thing we need to focus on is reducing anxiety, because it is embarrassing to have an STI. You may be dealing with a patient who contracted this STI perhaps from a cheating partner. You don't know what the situation is going to be, and so we want to provide a non-judgmental environment. We want to support them. We want to encourage them to discuss their concerns. You want to provide factual information and individualize your teaching. And you may need to help them in planning the discussion with their partners, because they may need to disclose, they do need to disclose that they have this infection. So sometimes role playing can help with that. A social work referral may be appropriate if you're seeing, potential sexual abuse, recurrent infections, maybe some high risk behaviors.